A 20-year-old right-hand dominant had a right small finger injury while playing softball. Later on, he quotes that the ball struck the tip of the finger and he thought that he has only jammed the finger. He did not seek any medical attention for further 10 days. When seen, he described persistent pain and lack of motion at the level of distal interphalangeal joint. Now, in this, differential diagnosis can be DIP joint dislocation or the fracture of the distal phalanx. Soft tissue injuries like mallet injury or avulsion of the FDP can be also thought. An X-ray was done which showed a dorsal dislocated DIP joint. No fracture was present. Dislocation of the DIP joints are not commonly seen. Most commonly is the dorsal DIP joint dislocation, which results from hyperextension injury. Often these DIP joint injuries are reduced in the field and never seek for medical attention. Most common, the DIP dislocation is on the dorsal direction following a hyperextension injury. The joint is inherently quite stable because of the strong attachment of the two collateral ligaments and the volar plate, which creates a box-like confinement. Flexor and extensor tendons as well as the tight skin adds further stability. The skin is so taut in this region that these injuries are often open with a Palmer wound. If this is the case, the wound needs to be explored under adequate anesthesia to be certain there is no contamination of the joint and to irrigate it as well. The diagnosis is straightforward. The major consideration in differential diagnosis are the various fracture of the DIP joint, and these can be easily excluded by a radiograph. Once reduction is obtained, it is very important to test the integrity of extensor tendons and FDP, as either can be injured with the dislocation. If missed, these injuries can be extremely difficult to treat. After the diagnosis, local anesthesia is administered. Lidocaine 1% without epinephrine is injected at the metacarpal block to anesthetize the radial and ulnar digital nerves, and then injected dorsally subcutaneous at the base of the finger to block the dorsal sensory nerves. Usually only 4 to 5 cc are required. Once the patient is anesthetized, the reduction can be obtained by longitudinal traction and flexion of the DIP joint for dorsal dislocation. Sometimes an exaggeration of the injury by hyperextension of the joint may be necessary to reduce. Avoid displaced injuries, traction and extension are usually required. Once the reduction is completed, the joint is first tested for stability, both passively and actively. Most important is to actively test for at the extension and flexion of the DIP joint. An extensor lag can be indicative of mallet injury and need to be splinted appropriately. A mallet injury would be more likely with the volar dislocation. If the patient cannot actively flex the DIP joint, he or may have sustained a FDP avulsion, which needs urgent treatment like any flexor tendon ligament injuries. If stability tested and AP and lateral radiographs are obtained to confirm the concerted reduction and to make sure there is no fractures missed. The injuries are rarely unstable and thus need no splintage. If the patient is comfortable, then the removable splint can be applied for a week. If there is instability, a splint can be fashioned to keep the joint in slight flexion. This would not be necessary for more than 3 weeks. In our case, interestingly, the attempted reduction failed. In such situations, it's necessary to remove the structure blocking the reduction. This is most often due to the interposed volar plate, which is still attached to the distal phalanx. Others have reported causes including entrapment of FDP tendon, buttonholing of volar plate, or osteochondral fractures. The surgery can be performed under metacarpal block. A dorsal H or a Y-shaped incision is centered over the DIP joint. The extensor tendon is retracted and the volar plate can be teased back over the head of the middle phalanx with a freer elevator. Joint stability is then tested, and as the patient is awake, he can also demonstrate active and passive range of motion. A C-arm image is obtained. In our case, the joint was explored and the volar plate was blocking the reductions. Once the joint was reduced, however, it still had tendency to sublux. Therefore, a 0.035-inch K wire was placed across the joint with the joint in extension. Post-operatively, the wire was removed after 3 weeks and active and passive range of motion was started. It is important to have the patient moving the metacarpophalangeal joint and PIP joint during the time of DIP joint immobilization. Talking about the complications, they are rare. Stiffness is a problem, but because these joints are typically stable after reduction, range of motion can be started immediately. The other concerns is missing and accompanying injury, which can be ruled out by actively motion testing and appropriate radiographs.